that we are able to host in person. In particular, I'd like to thank Dennis's family who's joined us to honor Dennis's memory today. His wife, Carol, and his daughters, Gina, Megan, and Nicole. Thank you for taking time to celebrate Dennis with us. Before I introduce our speaker, I want to tell you all a little bit about Dennis. Many of you had the chance to work with him and meet him, but we have many trainees that didn't necessarily have that opportunity, and folks that may be tuning in who know of Dennis's work, but maybe didn't get a chance to meet him. Dennis really started his GI academic career here at the University of Colorado. He did his GI fellowship with us. You can see a few familiar faces, but certainly Dennis considered the University of Colorado and the Denver VA his home from the inception of his training. He really developed a passion for colon cancer prevention in working with his longstanding mentor, Dr. Bill Brown, who many of us have the pleasure of continuing to work with. And in Bill Brown's lab, they were really doing some work on cell surface proteins and cancer cells. And the kind of budding scientist that Dennis was, he was very adamant that they have true controls, not adjacent normal mucosa to cancer cells and cancer specimens that they had, but true negatives, true controls. And so at a time where perhaps it was acceptable to do so, Bill Brown proposed that they perform colonoscopies on each other and get those true normal samples. And so, of course, Dr. Ahnen performed a colonoscopy on Dr. Brown and got that normal tissue for their controls. And then Dr. Brown performed a colonoscopy on Dr. Ahnen. And at the age of 33, as a GI fellow, like those of you sitting here, Dr. Brown diagnosed a 2-centimeter polyp in his rectum with high-grade dysplasia, advanced precancer cells, essentially a polyp knocking on the door to becoming cancer. Dr. Brown, of course, removed that polyp, and Dr. Ahnen always credited Dr. Brown with saving his rear, if not his life. And of course, Dennis used more choice words than that, but that really, gave a personal connection to this power of prevention in colorectal cancer, and was a part of many of the things that drove Dennis to commit his life to colon cancer prevention. Of course, those who are familiar with his work know the things that he's done to really advance our understanding of colorectal cancer pathogenesis, colon cancer prevention, chemoprevention in colorectal adenomas. Dennis was really fond of word clouds, especially for complex ideas. And for those who've had a chance to see him speak, and more recently, when asked what the keys to all of this success were for him, he always liked to present this word cloud. He always used to mention that these were the different characteristics over time that were the keys to his success. And those of us that had a chance to work with him and be his friend, be his colleague, we know that each of these things embody Dennis. In 2018, Dennis was awarded the Lifetime Achievement Award from the Collaborative Group of the Americas on Inherited GI Cancers, really a premier professional society dedicated to the care of patients with hereditary cancer syndromes. And at that time, we asked many of his friends and colleagues, mentors, mentees around the world what words came to mind when they thought of Dennis. And this is the word cloud that we created in his honor. And many of these characteristics are completely in line with what we all know about him as a scientist, as a colleague, as a mentor. Many of the terms, the scientific contributions that would not be present without his integral participation and integral role, some of which we'll hear about today. He was always committed as an educator and a teacher. He was a collegial friend and had connections and colleagues all around the world whom he touched. And he did all of this with grace and humility. And no one could ever imagine the 100+ page CV that this man had in having a conversation with him, because he approached everyone with humility and grace. Despite the pandemic, we all had a chance to connect with Dennis, and he was ever the storyteller. You can see that he has this deadpan expression here because he's just told us a hilarious story that has knocked Dr. Wani off his chair. You could see that the stoic Dr. Chaco is in stitches bending over on her desk at the VA. And of course, Dr. Frank Scott's earphones, which I think have been upgraded since then through the pandemic, have him engaged as well. But Dennis was ever the storyteller. And even when we were all separated by the pandemic, he stayed connected with us, which we will forever cherish. As Dr. Edmundowitz mentioned, I was really just so honored and lucky to be in his circle and benefited from his leadership, his mentorship, his friendship. And what's remarkable is that as much as I see myself as so special as a recipient of his generosity, he has mentees throughout our division over decades of service that can say the exact same thing. And in fact, he has mentees and colleagues around the world who would probably say the exact same thing. So going back to his keys to success, I think the thing that he always liked to emphasize is that really the most important word in this word cloud was his key decision to focus on family. And his lifelong partner and commitment with Carol was central to all of his success. He's built a beautiful family that lives on, and his legacy is really embodied in many of them. This touching note that he left for Carol on the back of a photo early on in their life just shows how caring and kind of a person he was. We're so happy to have his family here. I've seen them grow as I have grown up with them as well. And of course, the many grandkids that now live in his name. I, of course, am so honored to have had Dennis be a mentor, a friend, and a family member. And I, of course, inserted myself into his family without asking for permission. And I'm just so pleased that him and Carol and his girls, grandkids, son-in-laws are a part of my family. So it's really fitting that one of Dennis's lasting wishes was putting aside all of the bravado, putting aside all of those publications, all of those lifelong support of grants from the NCI, from the VA, but his most important priority was to make sure that his legacy of mentorship and education continues. And in that, he decided to establish this lectureship in 2019. And his goal was really to ensure that each of us, at least once a year, and if I had anything to do it, much more than that, but at least once a year, focus our attention on bringing a premier speaker to really highlight how important colorectal cancer prevention is. Since 2019, we've had outstanding speakers. Of course, Dr. David Lieberman inaugurated this lectureship in 2019, and despite the pandemic, we were able to virtually host Dr. Rick Boland last year. There's really no other person more fitting to be our lecturer for the 2021 lectureship than Dr. Jason Dominitz. We're so pleased to be able to host Dr. Dominitz. He's a professor of medicine at the University of Washington, the executive director of the VA National Gastroenterology and Hepatology Program. And in addition to shepherding the VA through colorectal cancer prevention for over the past decade, not to mention all the recent challenges with COVID, He's really a juggernaut of a researcher. He's a co-principal investigator on the largest randomized controlled trial within the VA system, the CONFIRM study, which we heard a little bit about yesterday and we'll hear more about today. 50,000 veterans across the country randomized to either fecal immunochemical testing or colonoscopy. He is a co-principal investigator on Department of Defense funding, looking at the effect of linaclotide on colorectal adenomas and colon cancer. Also a principal investigator on a study funded by the ACG and the ASGE looking at quality metrics in individuals getting colonoscopy after a positive fecal immunochemical test. There's over 100 peer-reviewed publications. He's received prestigious awards from our professional societies, including the AGA Institute Top Oral in Disparities Research, the American College of Gastroenterology Service Award for colorectal cancer. He's been awarded Seattle's top doc not once, but multiple times, and has received innumerable recognitions by the Veterans Affairs, the VA system, for his contributions to service, patient care, and quality. He has served our editorial boards of our major GI journals, including Senior Associate Editor for the American Journal of Gastroenterology. He's been a guest editor for Gastroenterology, Associate Editor for Gastrointestinal Endoscopy, and Editorial Board for Evidence-Based Gastroenterology. He's been on multiple national working groups through the VA, as well as our professional GI societies. He serves on the Multi-Society Task Force for colorectal cancer, which we all look to for guidance for colon cancer screening, as well as colorectal polyp surveillance. He also is on the AGA Institute of Quality Leadership and also on the ASGE Quality Assurance and Endoscopy Committee. He's the ASGE postgraduate course co-director. And really, in addition to all of these accomplishments and all of this service to our GI community, he's been an outstanding educator and mentor, has mentored numerous trainees and junior faculty. And so really no one more fitting that embodies commitment to colorectal cancer research, service to our GI community and our veterans, and mentorship and leadership. No one better that we can think of to really honor Dennis's memory. And so we're very, very pleased to have Dr. Dominitz. Dr. Dominitz, thank you so much.
Thank you. Thank you, Swati. That was an incredibly kind introduction. I'm not sure that half of it is true. You know, I don't in any way measure up to Dennis. Dennis was such an amazing individual, and I'm so humbled and honored to be here today to, in his legacy, to talk to you about colon cancer prevention. You know, I met Dennis over 2 decades ago, and he had me out here to Denver a couple of times, and I wish I got to know him better. I think we were good friends, but you know, I envy those of you who got to spend time with him on a daily basis, because he was just incredible. Those of you who worked with him or knew him, you know, knew how amazing this individual was. Swati did an incredible job explaining it, and she's much more eloquent than me. Dennis helped us design the CONFIRM study. She mentioned the CONFIRM study, which Doug Robertson and I, Doug is the guy on the far right, he and I came up with this idea back at some random VA meeting about some challenges with fit testing. We said we should do a study, and then at DDW in San Diego, we sat in an Irish pub one day over lunch and came up with the idea for the CONFIRM study. It was nothing like the study that's happening today. We had a planning meeting where we got shot down big time. Dennis was at that planning meeting. You know, when Doug and I came up with the idea for the study, it was going to be a randomized study of FIT versus colonoscopy with an outcome of advanced neoplasia. And CTC was the third arm, actually, CT colonography. And we presented the idea to VA leadership with people like Dennis Ahnen on our team to help us think through the process, and it got shot down. And they said, come up with a better idea. So we came up with it. We came to another meeting, and this was in Chicago. December 15th, 2009, and you see Dennis on the far left and David Lieberman next to him. And this is at Harry Carey's. And we spent the weekend trying to come up with a better idea. And then we proposed it to VA leadership. And the guy in charge said, I like it. But what I remember most about that weekend is not, I mean, this is a $100 million grant. That weekend, the strongest memory I have actually is from walking around the Chicago Museum of Art with Dennis and looking at these amazing paintings. And the whole time, Dennis, who I did not know well at the time, talked about Carol and his kids. Gina, Megan, and Nicole. And it was just, you know, like I was young, and here's this impressive, amazing guy. And we talked a little bit about research, but mostly he talked about his family and how important they were. And, you know, talking about having his kids live near him. And, you know, I think back on that, and it's like, that's the lesson I take from Dennis, more than all of the research and everything, is the family issues. And I'm really thrilled that they're here today with us. As I said, Dennis was part of the confirmed study, and here you see our kickoff meeting in 2012. And Dennis was part of the executive committee. You see him here sitting again next to David Lieberman. And again, 2013, there's Dennis. We had many executive committee meetings. Every month we met for an hour or so, and we would discuss challenges with the study. And every year we got together face to face and spent many hours together discussing things. And Dennis just has an amazing way of cutting through the BS and thinking through challenges. And he was just so insightful and practical, and also kind and generous. You know, you saw this word cloud already. Swati and I did not coordinate at all, but you know, as I said, she's so eloquent. All these words describe him so well, and I'm sure there's 1,000 more words, and the words escape me on how to talk about Dennis, because it's just so, it's so deep. You know, I talked about this a little bit yesterday at DDW. Whenever people gave presentations, you know, sometimes there'd be really bad presentations and I wouldn't know what to say. And Dennis always knew what to say. He'd get up and he'd ask a question in a way that allowed the audience to kind of redirect and think more appropriately about the issues that were brought up by the speakers, or he would challenge them in a way that was never offensive or insulting. He made people always feel respected. But I think one thing, you know, I could go on for the full hour and a half about Dennis, but he wants us to talk about colon cancer prevention. So in that regard, I think I'll move on and talk about colon cancer. And yesterday I talked about which test is best. I talked about the different screening options. And today I want to shift focus and talk about some of the challenges in implementation. Now, just to get us all on the same page, you know, I'm sure as a gastroenterology audience, you're all aware that colon cancer is the second leading cause of cancer death, about 150,000 new cases each year and 53,000 deaths. They're shocking statistics, and we need to do better. And here you see the, you know, when you think about preventing a cancer and cancer mortality, you want to be able to identify a preclinical phase that is treatable. And on the left-hand side, you see a figure from one of Dennis's papers. Dennis did so much to educate us about colon cancer, about the biology of colon cancer, and about epidemiology and interventions. You know, Swati had some examples of his work, and we could spend, you know, many hours going over his work. But we know by removing polyps, we prevent colon cancer mortality. And so here we have multiple tests that are listed by the US Preventive Services Task Force as recommended for colon cancer screening. And yesterday I talked about the evidence. You can see there's varying levels of evidence across the different tests, with some having randomized controlled trial evidence of mortality benefit, others having no direct evidence of mortality benefit. When you think about colon cancer screening, it seems really simple. You offer screening, they either screen negative or positive. If they're positive, if they're negative, you go back to offering screening at some point in the future. If they're positive, they get a colonoscopy. Or you can go straight to colonoscopy. And the VA 380 study that David Lieberman led and Dennis participated in helped set the stage for screening colonoscopy. Medicare started paying for screening colonoscopy in large part because of that study. And colonoscopy either finds cancer or no cancer. If no cancer, you go back to offering screening again or colonoscopy at some point in the future. Pretty simple, right? But it's not so simple and it's not so easy. We really do need an easy button. And for those of you who think about doing research, those of you who think, you know, everything in colon cancer has been studied by all these other people and there's no room for me, I want to convince you otherwise, because I'm going to talk about all the problems. I don't think I'm going to give you many answers today. I want to get you thinking about all the challenges and opportunities for us to learn how to do better. Because when you offer screening, who do you offer to? How do you offer it? How often? Which test do you offer to screen? And what cutoff value do you use for different kinds of tests? And then with colonoscopy, is the quality adequate? And I could fill this slide with 1,000 other questions. When you think about colon cancer screening, we look at the adherence. Cervical cancer screening is undertaken by over 80% of women, breast cancer screening over 70% of women. Colon cancer screening is lagging behind. We're getting better, as you see on this graph, but we still have a long way to go. And about 60% of deaths are attributed to non-use of screening. So if we can get everybody screened according to what's recommended, we'd reduce colon cancer mortality by at least 60%. So these are some of the challenges I'm going to address. And I know it's a lot on here. I'm always a little ambitious with my talks, and I tend to talk a little fast. I apologize. Feel free to interrupt me if there's questions or comments. But we're going to go through how to offer screening, how to improve adherence, et cetera. So I'll walk through each of these in turn. How to offer screening. So you define some inclusion criteria, an age range. And Swati Patel is one of the world's experts on what age range. We were offering it 50 to 75-year-olds, right? And then just in the last few months, the U.S. Preventive Services Task Force came out with recommendations to start at age 45. Very controversial topic for a while, and now it seems like we've settled that. But even starting at age 45, we know people get colon cancer earlier than that. Katie Couric's husband was younger than that. Chadwick Boseman was younger than that. You come up with exclusion criteria. You don't screen somebody who had a normal colonoscopy in the last 10 years, or reflex sig in the last 5 years, fit in the last 12 months, et cetera. Each of these are decisions about inclusion and exclusion. And the last one, you see limited life expectancy. Well, what does that mean exactly? And hospice is pretty clear cut. If somebody's on hospice, you probably shouldn't be screening them for colon cancer. Then you need to build in processes to avoid under-screening. If you're talking about screening with fecal immunochemical testing, should you be doing that in people who have a history of prior adenomas, or people who have a family history of colon cancer, or people who have symptoms? And we're going to talk about programs for mailing fit. But what do you do? What if people are having rectal bleeding or weight loss or iron deficiency anemia? You also want to build processes to avoid overscreening. I'll talk more about this a little later, but we do have a lot of overuse of procedures, which is inefficient and excessive and wasteful. Now, Swati and Dennis had this paper just last year. I talked about you want to exclude people from certain kinds of screening who have prior history of adenomas. There's also family history. Well, when they surveyed 137 people who have a history of advanced polyps, and these people are under age 60, the guidelines say that they should be screened in 3 years, and that their family members should be screened with colonoscopy, and starting at age 40. But when you ask these people what kind of polyp they had, only 28% said that it was a precancerous polyp. When asked about their personal risk, only 55% knew that their risk was higher than average. Most knew that their colonoscopy was due in 3 years. And only 40% knew that their first degree relative was at increased risk. I don't know why that popped up. And one of your former fellows, Jen Kolb, had a paper with others, including Dennis from your institution, talking about these barriers to getting people screened when they have advanced colorectal polyps. There's the lack of understanding, as we just discussed. There's lack of resources to educate people about the risk to first degree relatives. There's lack of resources about educating the first degree relatives themselves, and a number of other challenges that we need to think through when we're talking about getting the population screened. We don't have good systems in place. Does your electronic medical record allow you to record family history in a way that you can keep track of this and then notify the family members or make sure that they get notified? I've yet to see a medical record system that does this well. I know from the National Colorectal Cancer Roundtable meetings that this was a topic that came up time and time again, and Dennis would attend those meetings and talk about that and say, we need to build better systems. So there's a lot of avoidable cases of colorectal cancer out there because we're not doing all we can to make sure people know about family history. I mean, it's funny, I got involved in colon cancer prevention as a GI fellow. I fell in love with colonoscopy. This was before screening colonoscopy was a thing. The VA 380 study had just started. And I read this paper in the Red Journal about a practice in Indiana offering colonoscopy for $100. I don't know if people remember that paper, but a screening colonoscopy for $100, if they found a polyp, they charge your insurance and get whatever thousands of dollars they get for colonoscopy. And I said, that's brilliant. You know, we should be doing that everywhere. You know, we get the whole population screened. And my mentor, Dawn Provenzali, who unfortunately passed away earlier this year, she said, colonoscopy is too invasive. It's too risky. Nobody does a screening test like that. I'm like, but you're doing this study with it. And like, she thought it was too risky. I don't know if she still felt that way later, but you know, I thought colonoscopy was the greatest thing. And, you know, and then I found out that my grandfather had died of liver cancer, and my uncle on the same side, my mother's side, had died in his early 40s of liver cancer. And I started learning about liver cancer. I'm like, that seems kind of weird. And I don't know about hereditary liver cancers and what kind of risk. So I asked my mother, and it turns out my grandfather had an ostomy and my uncle presented with rectal bleeding. So I'm pretty sure that they both had colorectal cancer. I don't know, but I'm pretty sure. And so I got my colonoscopy at 40, had a complication. Of course, Dawn Provenzali was right, ended up in the ICU. So lost half my blood volume, but you know, there it goes. You know, when you look at how we offer screening, if you look in the VA, as Adam Powell did in this study of 900,000 fecal blood tests, 26% of them they said were potentially inappropriate. 14% were probably not due, and 8% were in people that they felt had limited life expectancy. But this isn't limited to fecal blood tests. It happens with colonoscopy as well. 14% of the screening colonoscopies were felt to be potentially inappropriate, 10% not due, 4% limited life expectancy. So we're not doing this exactly right. There's ways to improve this. Now in the VA, we have an average risk colorectal cancer screening reminder. It turns on at age 45, and it says colon cancer screening due, and the provider can go through offering fecal blood testing or colonoscopy or what have you. They can also say, no, we shouldn't screen this person because they've got, you know, life-limiting comorbidity, turn it off forever. Or they can say, we got other active issues going on, turn it off for 3 months. So there's things you can do to defer screening for a period of time. And if they get a colonoscopy, we have what's called the gap reminder, which the system was built. We worked on this it took 2-3 years to put this together, because the old colon cancer screening reminders look for a colonoscopy, and if they see a colonoscopy in the last 10 years, they would turn off, because colonoscopy is good for 10 years, right? But you all know colonoscopy is only good for 10 years if it's negative. If it's poor prep, if it's got adenomas, then the surveillance recommendations are usually shorter interval than that. So we have a gap reminder that now says, tell me what to do. Do I want the person to come back for a colonoscopy in 3 years, 5 years, whatever? Do I want them to get average risk screening again in 10 years? Do I want them to come back in a year? Do I want to say never screen again because they're 80 years old now? So we have a gap reminder to inform that. And there's actually these 3 reminders that work together. And if you say come back in 5 years from now, the colonoscopy reminder will come up. There's not an average risk reminder, there's a colonoscopy reminder that's there. So we try to build this system that we implemented across the VA in the middle of 2018, and 1.6 million gap reminders turned on when we turned it on. And the VA's been working to clean up those 1.6 million gap reminders to find out when people need their next colonoscopy. And part of the problem is the colonoscopy reports could be missing. We send them to the community, the reports are incomplete. They say polyps were removed, but you guys all know, you get these reports. Somebody says, I had a polyp 3 years ago. Was it hyperplastic? How big was it? All of these questions. So you cannot resolve these reminders without really knowing that, but sometimes you just have to guess. And that's what we do every day in medicine. Now, when you're offering screening, you can offer in different ways. You could offer fecal blood testing, you could offer colonoscopy. What they did in this Italian study was they offered FlexSig to 63,000 people, 30% followed up with the FlexSig. Then to clean up the 70% who didn't get screened, they offered FIT, and they got another 19%, excuse me. So you can by sequentially offering testing, you can improve adherence. You can also give people a choice rather than telling them to get a fecal blood test or get a colonoscopy, as was done by John and Nadomi in this study in San Francisco. One clinic, there's many clinics in San Francisco, but some clinics offered FOBT, some offered colonoscopy, and others offered a choice. And you can see that overall adherence was higher when FOBT or choice was offered. And you can see with choice, there was a split between accepting colonoscopy or FOBT. In Poland, they recently published this paper showing that they had 3 arms. If you just offer colonoscopy, you get about 18% participation. If you offer colonoscopy and then FIT, like the Italians did with FlexSig, you get up to 26% adherence. And if you offer a choice between colonoscopy and FIT, you get about 27% adherence. And when you look at the far right-hand side, the choice group, you see that more people chose FOBT, or excuse me, FIT, fecal immunochemical test, than colonoscopy. Now, this is the diagram of the confirmed study. We recruited 50,126 veterans who were randomized to screening, colonoscopy, or FIT. And we have 46 sites across the US, from Honolulu to San Juan, Puerto Rico, and just about everywhere in between, including Denver. And I want to thank Swati Patel and Jed Olson for being our local investigators running this study. When we look at the choice of tests that people prefer, this is based on the data from several thousand, actually over 7,000 people who declined to participate in the study because of some reason or other. And we asked them, why not? And 25% said they want FIT and 20% said they want colonoscopy. So there was a preference for non-invasive screening. And when we looked by region, we see that there's regional differences in that preference. In the Northeast, it was pretty even split between colonoscopy and FIT. But in the West, there was a strong preference for FIT over colonoscopy. Now, if you go back to John Anadomi's study from those clinics in San Francisco, he identified that race was also a predictor of which test people prefer. Sorry, let me go back here. As you see on the left-hand side, we see the data for African Americans, and the third bar is the choice arm, and you see that only 20% of African Americans chose colonoscopy, whereas among whites, 52% chose colonoscopy, and among Latinos, 24% chose colonoscopy, and Asians, 33%. So there seem to be racial differences in the preferences for types of screening, and this has been borne out in multiple studies. Now, another thing to think about when you talk about screening is that, colon cancer is the second leading cause of cancer death. It's incredibly important disease, but 1 out of 23 men and 1 out of 25 women will get colon cancer in their lifetime. We want to screen everybody because we don't know who that 1 out of 23 or 1 out of 25 is. Ideally, we would know who that is and target screening to those people, because the other 22 men and 24 women get no benefit from screening whatsoever, except some psychological benefit of the reassurance of a negative exam, right? So it would be great if we could risk stratify people and decide who needs screening and who doesn't. It would be better on the patients, it would be better on the healthcare system. We could target our resources. In Asia, they did this study where they took almost 6,000 people and risk stratified them based on age, sex, family history, and smoking. And then they offered FIT to those with lower scores and colonoscopy to those at higher risk scores. And through this simple risk stratification process, they were able to detect 71% of the advanced neoplasia and 95% of the cancers quickly. They ended up doing colonoscopy on everybody at the end to see what they missed in the FIT group. And so, we're just at the beginning of this. There are lots of studies trying to risk stratify people. And I think the day will come when we can identify who needs colonoscopy and who may be able to go with a less invasive screening option. Or perhaps we'd get smart enough that we would say, you're never going to get colon cancer in your lifetime. I don't know if that's ever going to happen, but that would be the goal. Now, there's also some differences in how the tests perform. I think this is really fascinating, this study from Holm et al. They looked at the data on FlexSig, and FlexSig reduces colon cancer mortality by 27% overall. But it's 33% in men and 18% in women. And actually, in the post hoc analysis, it doesn't really work in women over 60. So if you believe screening with FlexSig is the way to go, it probably isn't the way to go for women over 60. So, this is post hoc analysis. I think more work needs to be done, but I think we can get smarter about how we offer screening. I don't think one screening test is best for all, and we will get better at doing this. The problem with saying women should get this and men should get that and young people do this and whatever is you get complicated. When it gets more complicated, it may hurt adherence. A simple message is easier to get across than a complicated message and may boost adherence. So then how do we go about improving adherence? Well, clinical reminders are used extensively in the VA and Kaiser. I don't know, do you guys have clinical reminders for colon cancer screening in your health system? Yes, you do. Great. These prompts work well as long as it has the right information. If you have an integrated healthcare system, it works better than if you have a fragmented healthcare system. And if everybody getting care at your hospital gets all their care through your system, it'll work well. Or if Epic integrates all the data across all the private practices and all the systems where somebody could get a fecal blood test or a colonoscopy, it'll work. But we haven't reached that goal yet of integrating that information the way we need to. In Kaiser, they started doing what's called FluFit, and I'm sorry if it's cut off on the top of the screen, but this says the FluFit program. And what they do in Kaiser is they have the reminder system, and when you come in for your flu shot every year, if the reminder is due, they have fit kits available to hand them out at the time of the flu shot. And by doing that, as you see in the bottom row, they were able to boost adherence with colon cancer screening within 90 days to 30% compared to 15% in the control group. So they doubled the rate of screening just by this simple intervention. It requires coordination. You have to have fit kits at the flu shot clinic, and you have to have a computer so they can look up each patient when they get their flu shot. I mean, when I get my flu shot at the VA, they don't look me up in the computer. I just fill out a piece of paper, hand it to them, they give me a shot in the arm. But obviously this requires some coordination. Now there's a lot of other things you can do to boost adherence. Intensive education boosts adherence from 51% to 66%. And I'm just going to whip through a bunch of these things to give you some ideas about how we can go about improving adherence. Switching from the guaiac FOBT to the FIT boosts adherence from 39% to 48%, because the FIT kit, one test instead of one sample of stool rather than 3, no dietary modification. We don't know exactly why, but these are some of the reasons why adherence should be better with FIT. A mailed reminder, just sending people a postcard gets more adherence with FIT. Samir Gupta had this study where they looked at how many people participate in colon cancer screening over a set period of time, and with usual care it was 12%. When they invite people for colonoscopy, they get up to 25%. And when they invite them with FIT, they get up to 40%. Again, showing non-invasive screening yields better adherence. How about paying people to get screened? Now, this has always fascinated me. There was a study from the Philadelphia VA, Colgren et al. It's the third and fourth rows. They did a couple of different things. They paid people $5, $10, $15, $20 to complete a FIT kit, and it didn't actually work. Then they did a lottery, 1 in 50 chance of, 1 in 20 chance, I think it was, of winning $50, something like that. And people liked the lottery. It boosted adherence with the FIT kit. And you know, we see this like over the last year with the vaccine, right? You've heard about financial incentives, people getting paid, getting free tickets to a hockey game or a football game or whatever, getting free beer, getting $100, getting a lottery for $1 million, right? All these things to try to get people screened, get them their vaccine. People have been doing this for colon cancer screening and many other health interventions. So is it a good idea? The VA sent me to the Kennedy School of Government at Harvard a few years ago, and we had classes from a behavioral economist, and I was one of only 2 physicians in the room. And one of the readings they had was about this topic. And in fact, they talked about colon cancer screening and paying people to get screened. And I'll come back to that point in a minute. They said, you have to be really careful. The behavioral economist said, you have to be careful about this because people should get screened because it's the right thing to do for their health. If you pay them, people start getting a little suspicious about things, right? You pay them $5 to complete a FIT. Well, what's wrong with FIT? Oh, $5, well, it must not be that important. It's only $5. Some people are like, $5, great. I was gonna get FIT anyway. Now I get $5 to do what I was gonna do anyway. You say, I'm gonna give you $100. People are like, are you putting a 5G transmitter in that FIT kit? You know, like, I mean, you know, people start wondering what's going on. People get suspicious. And then there's the downstream effect. So you pay somebody to get the COVID shot, then you want them to get the flu shot or the booster. Like, what are you gonna pay me for this? Well, I'm not going to pay you for that. You know, we did it for that, you know, and then adherence may go down in the future if you pay people for something initially because you train them to expect money for something that they should be doing anyway. And in this meta-analysis that was just published this year, they found that financial incentives work for people who make a lot of money. They don't work for people who are at the low end of the income spectrum. They also found that the more diverse the population is, the less the financial incentives work. In fact, they really work for white populations in general from these studies. Now, this is a meta-analysis of these studies, but it raises these questions. So Rachel Osaka and I were asked to write an editorial on this paper, and you know, the boost in adherence was estimated to go from 30% to 33.5%. So there's some increase in colon cancer screening with financial incentives, But as I said, it works more for people who are more affluent, less diverse. And it actually worked better for people who were due for screening than who were overdue for screening. And it worked better in the short term than in the long term. If you look at short-term outcomes, it seems to nudge people, like, I'll give you $5 if you could do a fit now. And people are like, sure, I'll take the $5, I'll do the fit now. But they were gonna do it anyway. They just might have taken more than 3 months to do it. And so then there's the negative consequences downstream that I talked about. So we, in the end, in our editorial said, you know, probably time to move on and stop doing financial incentives for screening. Let's deal with other ways. It may be counterproductive. Patient navigation works. Take the money that you're going to pay the patient and pay somebody to navigate the patient through the system. Help them get screened. Navigation works as shown in this slide. Intention to treat from 20% up to 35%, so a 15% absolute increase in adherence. And per protocol of those people who actually went through the navigation, much higher adherence, as you would expect. But I showed you offering fecal blood testing versus colonoscopy led to greater adherence. This first set is from that John and Adomi study I showed you a few slides back. What's important about this paper is in year 2, adherence with FOBT, this is guaiac FOBT, was only 27%. It was only 14% in the 3rd year. So without ongoing support, occult blood testing falls off. You need to keep doing it. You know, so I was showing you just one-time offering of colonoscopy versus one-time offering of FIT or FOBT. So we really need to have systems in place to support people. So to summarize the different kinds of interventions for boosting adherence, outreach gives you a doubling of the effect on screening, navigation about 2-fold, you know, education works about 20% boost, and academic detailing, inReach, et cetera, all have some role. Now there are some technical challenges with FIT, and I'm curious to hear from the first-year fellows I understand sit in the front row. So I'm wondering, I'm going to pick on them a little bit. Think about what are some of the technical issues with FIT. I talked about the adherence problem. Can anybody think of any other challenges with screening, with non-invasive screening like FIT? I put them on the spot, sorry. Diet. Well, so with guaiac fecal blood testing, there can be dietary issues. That's true. But with the fecal immunochemical test, unless you're Jeffrey Dahmer, you don't have to worry about it. Sorry for the reference. So false positives that may lead to colonoscopies don't need to happen. Good point. Yeah, there definitely are false positives. The positivity rate with FIT is about 5 to 7%. About 5% of those people have colon cancer. So most of the people do not have colon cancer when they're FIT positive. That's right. Anything else? The amount of stool, yeah. So in the confirmed study, so I didn't show you the collection device, but it's like this size of a pack of Wrigley's gum. You have a little stick, you put paper on the water. For anybody who doesn't know, you put paper on the toilet water. You have a bowel movement, you take this little stick, you stab it into the stool, you put it into the collection device, which scrapes off the excess stool, and you have a relatively standard amount of stool in this buffer. And then you mail it in or hand it into the lab, and they shake it up and they assess how much human hemoglobin is in that buffer. And if it's above a certain threshold, then it's a positive result. If it's below, it's negative. We actually had a patient who sent in I didn't see it myself, and I'm kind of glad I didn't, but we got a package and the lab called us, and we have a central lab in Albuquerque, and they said, this guy packed so much stuff in there, nobody wanted to touch it, and you know. So yes, that could be an issue. Well, I'll put you out of your misery. There's a few other things to think about. So the U.S. Multi-Society Task Force, which Swati mentioned, but what she failed to mention is that she is a member of the U.S. Multi-Society Task Force. So we're very lucky to have her on that task force. We wrote guidelines on use of fecal occult blood testing, and it's like anything else in medicine. You can have a quality assurance program around this. So you offer FIT, is it completed or not? Is it received? You know, it's received by the lab. Is the sample okay? Is it positive or not? Then you need to get a colonoscopy and, you know, go back into recall at some interval. Well, so we had some quality targets. 60% of people is the target that should complete the test. I showed you in other studies, it was more like 48, 50%, right? So the target we're saying is 60% completion. And less than 5% of kits rejected. So this is one of the technical issues. Why would kits be rejected? I mean, it's pretty simple, right? You just put a stool sample on the kit and mail it in. I'll come back to that in a minute. And you want at least 80% of the people who test positive to get a colonoscopy. And I'll touch more on that topic in a bit. So here we see the hemoglobin concentrations over time. And this slide is showing you time from 10 days to 14 days. Now the test, for those of you who are not aware, the test is FDA approved or cleared, I'm not sure which, for 14 days from the time of collection. Okay, so you deposit a sample in the kit, you're supposed to write the date on it, you mail it in or hand it in, and then the lab gets it. And if it's more than 14 days, they're supposed to throw it away. Now, if they refrigerate it, it might last longer, but they don't know if it's refrigerated. If they don't write the date on it, what are they supposed to do? Simple thing like writing the date on that kit can cause, or lack thereof, can cause rejection of the kit. Now, how often are you going to get, you can't write it up for the patient in advance, say complete this, next Monday. You don't know when they're going to do it. Oh, and going back to this, you note that the hemoglobin concentrations fall over time. And so what's nice is that the colon cancer, so the threshold that's used commonly is 100. Anything over 100 is a positive test. So you see the colon cancers are well over 100. So maybe you could go out 2 weeks, 3 weeks, 4 weeks, who knows how long you can go before colon cancer would turn negative. But the advanced adenomas is the black triangles, and the black circles are minor adenomas. So the sensitivity of the test for neoplasia falls over time, because the human hemoglobin is degrading over time. In the confirmed study, we had a 5% rate of unusable kits. 4% were out of window, meaning beyond the 14-day window. And so here I'm going to show you the early data from confirmed. So this is, we started in 2012. We had 15% of kits were unusable. Why is that? Well, the post office was treating them like bulk mail. We paid first-class postage, but you all have heard about the post office a lot lately. Well, this was before all the news, but we went to post offices all around the country and asked them, what are you doing with our FIG kits? And like, oh, it's bulk rate mail. It's like, no, it's first-class mail. Deliver it now. So we put a sticker, first class, a big red sticker, first class, and it worked. Simple, right? And then look what happened. Like, what the hell is going on in December of 2013? Well, Christmas cards. And our kits are about the same size as Christmas cards. They can just get stuck with everything else that's getting mailed then. I mean, you guys get Christmas cards like 2 months later. Maybe it's the person who mailed it, they're late like me. I'm usually like 3 months late, but sometimes it's the post office. So then we switched to using priority mail. We pay like $10 per kit to do priority mail. These are some of the technical challenges. There's also temperature. Human hemoglobin degrades with temperature. This is from Kaiser. And in the kind of peach color is the average temperatures, the highs and lows, and in black is the positivity. Note when the peach is high, the black is low. So you're cooking your samples, right? And so in Israel, they use a 50 threshold. They don't use 100. It's hot in Israel. How hot is it in Las Vegas? How hot is it in Miami and Dallas? We actually mailed 3M temperature probes from San Juan, Puerto Rico, and Dallas and Honolulu to see the temperatures. And it actually was better than I expected. But in the confirmed study, the positivity rate falls in the summer. Now, maybe the sensitivity for cancer is still really good. Maybe we're improving the specificity. Nobody knows. Nobody knows. In the Los Angeles VA, they had a high rate of rejected kits for the reasons we just talked about. Mostly they were expired. They were too old, no date and time. So they had a quality improvement project. They put a big red note on for the veteran, mail it within 48 hours of collection. They allowed the lab to enter orders. Sometimes the FIG kit would arrive, there was no order. They'd throw it away. It's like, no, don't throw it away. Put it in an order. We've had problems where we use barcode mail and there's postage issues. We have hundreds of FIG kits arrive one day that have been collected over the last few months. Why? Somebody didn't pay the postage bill. There's crazy things that go on. So not in confirm, I'll add. So they also revised the clinical reminder. So the nurses would emphasize these points when they hand out FIG kits. Make sure you mail it in right away. And they allowed satellite clinics to write the date on when people bring it in. They're like, what day do you have that bowel movement? Oh, that was 3 days ago. Okay, let's write that date on there. And then they bought new label printers because sometimes the labels were illegible. They didn't know what veterans sent it in because it was all handwritten. And they were able to improve the rejection rate in the black line down from close to 30% to below 10%. So there's things we can do to improve the processes of care. Now, if somebody's FIT positive and they don't get a colonoscopy, that FIT did them absolutely no good. We need to get them a colonoscopy. And we know from multiple studies that the longer you wait from FIT positive to colonoscopy, the worse the outcomes are. This is the Doug Corley study. There's many others. If you look at the bottom section, you see that If you wait 7 months or more, the chance of advanced stage colon cancer is significantly higher. Now in Kaiser, their rates of getting colonoscopy were around 70% in the lowest graph, and they were able to boost it up above 80%. What'd they do? Well, at baseline, they had an integrated electronic health record, they had a focus on prevention, they had support staff, but they hired more GI docs. Good news for like Stephen Mundowitz, probably wants more GI docs. You know, they built new endoscopy units, which you guys have a beautiful one here. They increased the number of colonoscopies. They started sending fit letters, the certified letters to people who were fit positive. They removed the copay for colonoscopy. They started setting a goal for the institution of getting over 80%. They started penalizing facilities that didn't hit that target. They started giving GI the authority to manage these patients without waiting for primary care to send them. A fit positive generated an automatic consult to GI without anybody else having to interfere. Now, that's probably good for most patients. There may be some who the fit was inappropriate and they shouldn't have had it, and you know, they show up on your doorstep for their colonoscopy and they've got end-stage COPD or something else. So there's always some trade-offs when you do things like this. And they put in navigation systems and brought in primary care only at the very end if they couldn't get anything done otherwise. Now in the VA, we get more like 50 to 60%, lower than that in some regions. My VISN is VISN 20, that's Seattle and all of Washington, Alaska, Idaho, and Oregon. And we're getting close to 60% at 6 months, but it's not good enough. So we put in, I told you about these 3 reminders. We have another reminder. It's the fit positive reminder. Anybody who's fit positive has a reminder that says colonoscopy due, and people should order a colonoscopy or say why not. And when we look at reasons why people say why not, this is a relatively small sample looking at 300 charts. A third of them we thought were inappropriate. They said the patient's the wrong age. They're not 50 to 75, they're 45, they're 78. I don't buy that as a reason not to do a colonoscopy. They had a colonoscopy more than a year ago. Well, if somebody had a colonoscopy 2 years ago and they're fit positive now, you should be offering them colonoscopy today. You should have that discussion. Now, if somebody had a perfect colonoscopy yesterday and is fit positive today, I'd probably be discouraging them from having another colonoscopy. Like, I just did your colonoscopy yesterday, you're fit positive today. I don't think I missed anything. Of course, we know we missed stuff, but you should have the conversation with the patient. If it was 5 years ago, 10 years ago, there's no doubt you should be doing colonoscopy. And so these 25% were more than a year ago. 6%, the repeat fit was negative. No, fit negative cancels out a fit positive. I'm sorry. Once fit positive, they're fit positive. And somebody said they don't have symptoms. Well, I'm sorry. We're talking about screening. They're not supposed to have symptoms. We did a program in my VA where we started putting notes in the chart to alert the provider whenever everybody's fit positive. We were able to boost the rate of referrals for colonoscopy. Now, moving on to another topic, discordant results. So what do you do if somebody has a positive CT colonography? It says there's a 1 centimeter polyp in the transverse colon, and you do a colonoscopy, you don't see a polyp. What should you do? I'm curious if anybody would repeat the colonoscopy, screening colonoscopy or screening CTC, positive for 1 centimeter polyp in the transverse colon. You do a colonoscopy, high quality exam, you've got a high ADR, you don't find a polyp. Do you put them in 10-year follow-up? Do you do another CT? I see people shaking their head no. Do you do another CTC? What do you do then, right? So from a healthcare system perspective, this is a problem. If you look at what Perry Pickard's group says, now Perry Pickard's group is the group that developed CTC, is most famous for publishing this out of the University of Wisconsin now. They say that, they say 22% of the time the colonoscopy was falsely negative. Colonoscopy missed a tubulobilous adenoma. I mean, 22% of the time we miss something. Well, if you look at tandem colonoscopy studies, 22% of polyps are missed. I mean, it's identical number. So their preferred approach is to repeat the CTC. Of course, they're radiologists, but sometimes it was a false positive CTC. So, from a healthcare system perspective, this is a problem. When the modelers model this stuff out, they never model out that we're going to repeat the CTCs or repeat the colonoscopies in these patients. They assume negative colonoscopy, 10-year follow-up. Same thing with Cologuard. How comfortable are you? You have a Cologuard positive patient, you do a colonoscopy, it's negative. Are you going to tell that person come back in 10 years? I see some people saying yes. Okay, anybody feel differently? Nobody's saying they feel differently. Well, in this study, they looked at the chance of future cancers, air digestive cancers, lung cancer, pancreatic cancer, colon cancer. In the group that had the negative colonoscopy but positive Cologuard, 2.4% had a cancer within 5 years on average, versus 1.1% in those who were Cologuard negative, colonoscopy negative. So that risk ratio is 2.3, which typically epidemiologists say anything over 2 is important. But note the confidence interval crosses 1, so it was not significant. So it depends on how you look at this. The authors of this paper, which are from the manufacturers of Cologuard, say negative colonoscopy after a positive Cologuard, no further testing. I'm really curious what people do about this. I've had former fellows of mine reach out to me and say, what should I do? I had a high quality colonoscopy, they were Cologuard positive. We don't know if they're Cologuard positive because of FIT or because of DNA changes. The test does not report out that kind of information. And in this editorial, Doug Robertson and I said it was whether it's if you're a glass half empty, glass half full kind of person, because if there was one more cancer in that discordant group, it would have been significant. So I think that study was too small to reliably answer that question. We need more information. And I'm doing a study, as Swathi mentioned, funded by the ASG and ACG, looking at GI quick data. That's when our question is really, what do people do? We're looking at people who are FIT positive, Cologuard positive, screening colonoscopy. We're gonna look at the negatives and see what the recommendation is for follow-up. My guess is that people are gonna recommend faster follow-up for Cologuard positive patients than they do for FIT positive patients than they do for screening colonoscopies, right? I mean, the same is true for FIT, but most people that I've talked to seem quite comfortable saying 10 years after a FIT positive colonoscopy negative. Yes. I wait 10 years. Well, so I've never scoped a Cologuard positive person because I work in the VA and Cologuard is not used in the VA very much. So I can't answer that. But for FIT positive colonoscopy negative patients, 10-year follow-up. I'm very comfortable with that. Now, if you look at the data on people who are FIT positive, their interval cancer rate is higher than screening colonoscopy. So there's no doubt that it is risk stratifying people, and there may be some there is some excess risk there. So now, high quality colonoscopy. This is really a passion of mine. Yes.
So quick question, just to follow on that. We get a Cologuard, Cologuard sometimes do it. I do actually say that this average risk is pretty back 10 years because I know the data about FIT, that they are actually playing increased risk of interval cancers. And I figure, well, if I'm going to push out the positive FIT after a negative colonoscopy failure, I should really do the same for Cologuard.
Right.
So
yeah, so the comment is that you do the same thing for Cologuard positive, colonoscopy negative as you do for FIT positive, which you go 10-year interval, but you look harder. And actually, Doug Robertson has an editorial on I think it was the Johnson paper on Cologuard, saying that people look harder when they're Cologuard positive. When you look at the withdrawal times on people who are Cologuard positive, the withdrawal times are longer than screening colonoscopy. People definitely look harder. Maybe we should be looking that hard in everybody, right? But people do look harder, you're right. So high quality colonoscopy is a passion of mine. I took this job as the executive director 10 years ago to try to develop a quality assurance program in the VA for colonoscopy. And you guys all know we want, complete to the cecum, high quality ballot prep, high quality exam of the mucosa, high lesion detection, high quality polypectomy, appropriate surveillance recommendations. It needs to be timely and efficient. Now, people generally get to the cecum 95% of the time in the US, but there are people who do not have high cecal intubation rates. And when you look around the world, there's some scary data out there. When you look in the US, you find some individuals who don't have high cecal intubation rates, but this study from Canada showed clearly that if the cecal intubation rate is lower, the risk of interval cancers is higher, as you would expect. They miss stuff in the proximal colon. The technique of colonoscopy withdrawal is really, I think, the most important part. People have focused a lot on withdrawal time. I'll show a little bit of data on that, but it's technique more than time. The withdrawal time can be gamed. I've heard people talk about the rectal waiting time. They pull the scope back. They ask the nurse, how long has been my withdrawal time? It's been 4 minutes, doctor. Oh, I need to be at least 6 minutes. So let's sit in the rectum for 2 minutes. Nobody benefits from that 2-minute rectal waiting time, but it does make your numbers look good, right? So this study from Bob Lee, they videotape people's colonoscopies, and they had other people just rate the quality of the technique and not knowing anything about the doctors. And they were able to group the doctors by these scores into low adenoma detectors and high adenoma detectors. It correlated with the ADR. You're looking at distension of the colon, cleaning, looking around the corners, et cetera, flattening folds. And I mentioned the 22% miss rate. This is tandem colonoscopy studies. We know we miss polyps. Generally, we miss smaller polyps. We less commonly miss larger polyps. And, I apologize to those who heard my talk yesterday because there is some redundancy. I try to keep it to a minimum, but this I think is a great study. I think withdrawal time is a great measure when you look at it retrospectively. If you tell people we're going to measure your withdrawal time prospectively, people do the rectal waiting time thing. So intervention studies have not shown that it really helps boost ADR very much. But retrospective studies have shown a nice correlation like this one. You see in 51 gastroenterologists in Minnesota, the average annual withdrawal time for negative colonoscopies. And you see everybody who's over like 8.5, 9 minutes is pretty flat. But below that, the y-axis is the interval cancer risk. It's shocking what that risk of interval cancer is. I mean, how do we let people get away with doing colonoscopy with a 4-minute withdrawal time when their risk of interval cancers is 5 times higher than the people who spend 9 minutes? It's shameful. Honestly, it's shameful. How do we let this happen? The insurance companies don't pay us more to take more time doing colonoscopy. Maybe they should. How do we make this system better? This is the thing that I lose sleep over. In the VA, we do 280,000 colonoscopies a year. We have 6 million beds we're responsible for. We all should feel this way about taking care of our patients. And I'm sure you guys have, Sach and Lonnie, you guys, all the people invested in quality. How do we make sure that all of us have the same interest in assuring quality and don't give in to the pressures of the RVUs and whatnot? And we know that as adenoma detection rate increases, we reduce the risk of fatal cancer. You've probably all seen this slide, but in case there's somebody who hasn't, I will just walk you through it quickly. In Kaiser, they divided endoscopists into 5 quintiles based on their adenoma detection rate. The top quintile has an adenoma detection rate of 34% to 53%. The lowest, 7.4% to 19%. The benchmark is 25%. That's what's published right now. You should detect adenomas in 25% of men and women. And so you see the middle quintile happens to include that number. And every 1% increase in adenoma detection rate is a 3% decrease in the risk of interval cancer and a 5% decrease in the risk of fatal colon cancer. So we need to make sure we're all doing high quality colonoscopy. The people on the left-hand side of this graph need to be retrained, do something different to get their adenoma detection rates up because it's not fair to their patients. So as I said, the VA, we have 280,000 colonoscopies. There's 1,034 individual endoscopists who scope at the VA around the country. And I don't know how good they are. And I feel like I should. In fact, the OIG tells me I need to know how good they are. So we were talking about that last night. I'm working on this. I've been working on it for 10 years. Hopefully someday soon I'll be successful. When we look at data from the CONFIRM study, 17,000 screening colonoscopies, this is how good we are. These are not special colonoscopies that were done. These are routine screening colonoscopies done in the VA. We did not do anything different to make these study colonoscopies. Sorry. So you see that on average in the CONFIRM study, our adenoma detection rate is 46%. Remember, the benchmark's 25%. It's 30% men and our population is 94% male. So let's say 30% is the benchmark. This is based on individual facilities. So the lowest facility has an adenoma detection rate about 33%. That worries me a little bit, honestly, maybe more than a little bit. I don't know which site that is, but I'm going to talk to them. We've been doing a lot of work in the VA to make sure everybody's adenoma detection rate is higher. And this is at the site level. This is not at the individual provider level. If you get the individual provider level, now my sample sizes, my numbers are too small, I can't calculate it. But if you did that, I'm sure we would see even more variation. We'd see people who had scary numbers. I have no doubt. This study comes from Brennan Spiegel's group when he was in Los Angeles, and I love this study. So Brennan felt like the adenoma detection rate is good, but not good enough, because you don't want to find one adenoma and remove it. You want to find all the adenomas and remove them, right? But the ADR just says one or none. So the optimal endoscopist would be in the upper right-hand corner. I apologize for my slide management skills here. So this is probably the best endoscopist if this, the small circle means it's a small sample size. If you're going to get a colonoscopy, this is who you want, because their adenoma detection rate is very high and their ADR plus is high. ADR plus is the number of adenomas found beyond the first. It's a metric Brennan made up. And so all these people in this quadrant are optimal. Now this guy, he's an all or none. He either finds a lot of adenomas or none. His ADR rate is scary, 15%. These are the none and done. They just put the scope in, pull it out, collect $2,000. We did a study in a private practice not too far from me where we had stopwatches, and we had a guy whose average withdrawal time was 2 minutes. Okay. So scary stuff going on out there. And then these are the one and done. They find one and they say, ah, I hit my ADR target. Let's pull the scope out and move on to the next patient. Now we don't measure ADR plus. It's hard because, you know, you put multiple polyps in a bottle and, you know, if you put every polyp in a different bottle, that would raise the cost. And, you know, pathologists might be happy with you. They might complain about all these extra bottles you're sending them, who knows? But we're not doing as good of a job as we could at making sure that complete colonoscopy is done to remove all the adenomas. And the other thing that is interesting about this is that the blue dots were the VA endoscopists and the tan were non-VA. These were all veterans with screening colonoscopies. And so in the VA, I'm proud to say that in the VA, we did a better job. It was statistically significant. You know, I'm under a lot of pressure to increase throughput to get more colonoscopies done. And I show them this data and I say, well, you want me to do half-hour colonoscopies? This is one of the trade-offs. The faster we do the colonoscopies, the more polyps we're going to miss them, you know. So we have to decide what we want to do. Do we want more colonoscopies or do we want more high-quality colonoscopies, et cetera? These are the things that keep me up at night. So we're building this system. Tanya Kaltenbach, Andrew Garwin, and others are working together to build what we call the VA Equip, the VA Endoscopic Quality Improvement Program. And you know, but finding the polyps is only part of the story. Then you have to completely remove it. I know I want to leave time for discussion, so I'm going to pick up the pace a bit here. We need to completely remove the polyps, and Heiko Pohl's study demonstrated that complete polyp resection is not a guarantee. 10% of the time we have incomplete resection, and it varies by endoscopist, as you would expect. Using a cold snare technique is now the way to go for most polyps, and by getting that room of normal mucosa, we should, you know, reduce the risk of any residual neoplasia. So I think we all need to learn to move this way. And your group put together this nice paper a couple of years ago on the CSPAT. I don't know if that's how you pronounce it or not. The cold snare polypectomy assessment tool, you know, trying to make sure that people are doing high quality colonoscopy. And, you know, this is, I think, the next frontier of colonoscopy quality assurance, making sure, you know, adenoma detection's, you know, great. It's really moved our field forward, but we need to move beyond that to like ADR plus and complete polypectomy. And how do we do this? Can AI help us? I mean, this is really labor intensive. So how do we make sure people are doing a good job? You can't do it on every polyp unless AI can figure out a way to do that for us. We also have problems with surveillance. Now, Rocky Schoen published this study from PLCO. What you see highlighted here are people who have no adenomas, who had a complete colonoscopy, and note that 26% of them had another colonoscopy within 5 years. Now, why are they getting a colonoscopy within 5 years? These are not family history people. These are, you know, average risk screening, you know, the people who had a colonoscopy, and that's too high a rate unless they develop new symptoms or something. So that's probably overuse in most cases. But we also have underuse. The bar highlighted here, the line highlighted here are people with advanced adenomas. They should get a 3-year colonoscopy, and at 5 years, only 58% of them have been scoped. So that number's too low. Scary. How do we do better? In the VA, we have the same problem. Overuse is not simply because people want to make more money. In the VA, people do overuse too, and we don't get paid more to do more colonoscopies. So there's other factors at play. In the VA, we have instituted these quality metrics, you know, cecal intubation rate, bowel prep quality, surveillance recommendations, adenoma detection rate. I put these into policy a few years ago, and we're trying to make sure everybody's monitoring these metrics. Chief of staff's responsible for monitoring it. We need to do better. Now, I want to spend a few minutes talking about disparities in colorectal cancer screening. If you look at colon cancer incidence, we see for African-American men and women, the rates of colon cancer are much higher than for non-Hispanic whites. Similar for American Indians and Native Americans. If you look at mortality, we see the same disparity. African Americans have higher colon cancer mortality. The younger adults on the left-hand side, 50 to 64, on the right, 65 to 74. So we have disparities in mortality. Even when you adjust for stage, mortality is higher for African Americans. Here you see data, I just ran this a few days ago from the SEER website. In the kind of lavender color perhaps is Blacks, including Hispanics, and the rate of colon cancer, this is mortality, has been falling. That's great news, but still the disparity from Hispanics of any race, whites, and Asians persists. When I was a fellow, I attended a little poster session at GlaxoSmithKline in the Research Triangle, and I met this guy named Greg Cooper, and he had this poster showing that Blacks with colon cancer were less likely to get surgery than whites, 68% versus 78%. And among those who got surgery, mortality was higher. So he said, these data may indicate racially biased differences among Medicare beneficiaries in access to and quality of care for colorectal cancer. This is Medicare data. And I said, well, the VA isn't Medicare. And I was a fellow and I was learning how to do statistics. So I said, let me replicate your study. And Greg helped me. This became my master's thesis. And what we found is that blacks and whites in the VA had the same rate of surgery, the same rate of chemotherapy, the same rate of radiation therapy, but blacks still had higher mortality. So my takeaway from this was that access to care, which the VA reduces the barriers to access to care is one of the major reasons why we're seeing differences with Medicare. That's my hypothesis. You know, Medicare, although it's insurance, there's still a lot of copays, and I think that's a barrier to care. If you look at the Healthy People 2020 data, we see these disparities. So the target is that dotted line at 70% in terms of percent screened. And 2007 is the open circle, red circles are where we missed the target in 2017, and we see we missed it for men and women, whites, blacks, et cetera. Every racial group, urban, rural, we missed it. We missed it everywhere except people with an advanced degree. So I got screened. But you notice that there's differences. Rural is lower than metropolitan, the uninsured, way, way down. No surprise to anyone here, I'm sure. And education has this nice linear association with screening. These are disparities that we need to think about and do something about. If you look at mortality, we see in blue, we hit the target. Mortality, we're getting better at reducing mortality, but we still miss the target for men, for blacks, and for rural Americans. So we need to do better. In the confirmed study, we have 50,126 veterans. 56% of them have been screened in the past with some kind of test, but they had to have like a negative FOBT or a negative colonoscopy, and the colonoscopy had to be more than 10 years ago. So we just reported this at DDW. Here you see the differences in prior screening with any kind of screening by race. And you see that blacks look lower, but if you do a multivariable analysis, this is any prior screening. I'm sorry that the top is blocked by this, bar, but women have higher rates of prior screening than men, probably no surprise. There was no difference by race in the adjusted analysis, nor ethnicity. There are some differences by education and tobacco use, as you see below. If you look at prior FOBT, the bars bounce around a little bit by race, but what you see most notably here is that blacks were more likely to have FOBT. Think back to that John and Adomi study I showed you, where blacks were more likely to choose FOBT and whites were more likely to choose colonoscopy. Well, when you look at prior colonoscopy, we see exactly what John and Adomi found. Blacks were less likely to choose colonoscopy. This is prior screening. We have no idea if they chose it or that's what they were offered. I don't know the details. If you look at Fola May's data from looking at VA data, this is not part of Confirm. She found actually that blacks were more likely to be screened in the VA in her adjusted analysis, 18% increased odds of having been screened. Hispanics more likely to have been screened than whites. Asians, 34% more likely to have been screened. Unfortunately, American Indians, Alaska Natives, less likely to be screened. So what are the factors contributing to this? In the VA, we have relatively equal access. There still are barriers, but these are things we need to think about for our system. And I won't take time to talk about this, except to say, these are the associations between, in our 17,000 screening colonoscopies, between various demographics and other factors on the left and the findings of adenomas, advanced adenomas, and striated polyps. Blacks were less likely to have adenomas, advanced adenomas, and striated polyps. Now that could be good news or it could be bad news. It depends on what explains it. It could be that they're less likely to grow, to develop adenomas, advanced adenomas, or striated polyps. Or maybe we're less likely to find them, to look for them. Maybe we're not doing as good of a job. This data was published by Stacy Fedwa from the American Cancer Society a few years ago. What you see in the solid black line is the risk of interval cancer in whites. And then the dotted line is the risk of interval cancer in blacks. Note that blacks have higher risk of interval cancer. And when they look at polyp detection rate, blacks are more likely to be scoped by somebody with a low polyp detection rate. So is that true in the VA? Is that why we have lower adenoma detection rate? I have no idea. I plan on looking at that, but we don't know right now. We also found in the confirmed study that among people who are FIT positive, we looked at who gets colonoscopy within 60 days. And I know there's a lot on the slide. Let me just focus on this. Blacks are less likely, or non-whites, I should say, were less likely to get colonoscopy within 60 days than whites. Is that patient factor, system factors? I don't know, but it's a difference. John Carruthers and Chaik Dabani had this nice paper last year in Gastro talking about some of their thoughts about how to improve health equity around colon cancer. And a lot of data on here, and I want to leave time for questions. So I'll just touch on a couple of points. At the top, they talk about promoting information sharing, removing financial barriers for colonoscopy, for screening, biopsy, and follow-up testing. If you're FIT positive, that FIT test is free. The Cologuard test is free, but the colonoscopy that follows it is not covered by insurance as a free preventive health screening. It has different copays. They talk about promoting healthy lifestyle and access to resources, including navigation and transportation. They talk about implementing system levels issues to get screening out into the field, and I'll touch more on that in a moment. Race is complicated, and race is not simply biologic. There's socioeconomic factors. You all hear about systemic racism. It's been in the news so much lately, appropriately so. Lower socioeconomic status, lower education, difficulty in access to healthcare has downstream consequences. People have lower paying jobs. They have trouble making ends meet. They have food deserts. They can't afford healthy foods. That more exposure to tobacco and alcohol, less physical activity, that changes the gut microbiome. This gets back into Dennis's work, right? Understanding the pathophysiology of colorectal cancer. You get local procarcinogens and other byproducts that increase inflammation. And this may be what's causing colorectal cancer to be more impactful in these groups. Now, I want to touch on two more points. I'm going to go quickly through the pandemic. When the pandemic hit, we stopped all elective non-urgent procedures. People started estimating how many colon cancers are going to be missed. This study said 18,000 colon cancer diagnoses will be delayed. This is GI Quick data that Audrey Calderwood and I published recently, looking at the numbers of colonoscopies by month in GI Quick, which is looking at 700 different endoscopy units around the country. And you see that sharp drop, and this data goes through September of last year. The numbers had not recovered. Interestingly, and not surprisingly, I think, the numbers of colon cancers diagnosed dropped. Overall, I think there were, let me go back, there were 30% fewer diagnoses of colon cancer during the pandemic. But the proportion of colonoscopies done that diagnosed a colon cancer went up because we did less screening and surveillance and more diagnostic exams. This is VA data. We had a sharp drop. As of July of this year, we were only at 83% recovery of colonoscopy volumes. Our volumes are still down. Pre-procedure testing, loss of nurses, lots of factors playing a role there. Here's our colon cancer screening data in the VA. Now note the y-axis, it goes from 76% to 84%. So pretty good numbers. I mean, we've been over 80% since 2009 until 2019. Now there was a change in 2019 where the way they measure colon cancer screening adherence has changed a bit. But the numbers got worse during the pandemic. And so, as soon as I was part of the team that decided to cancel all colonoscopies, and then I started losing sleep over all the patients we're not scoping. So what are we going to do? Well, let's increase FIT. Let's start getting FIT into the hands of people. And if they're FIT positive, we scope them despite the pandemic, right? So what you see is we boosted FIT ordering a little bit by about 7%. I hope the numbers are higher since March of this year. But FIT, people weren't being seen in clinic. They weren't handing FIT kits to people. They weren't handing FIT kits to people anymore in clinic because it was all telemedicine. FIT results are down a bit, but there's some censoring of data that may be factoring that. But note, the colonoscopy numbers are down by 52%. Screening colonoscopies are down by 77%. And we have 560,000 veterans who need diagnostic colonoscopy now or surveillance colonoscopy now. We only do 280,000 a year. We have 1.6 million people due for colon cancer screening. I can't do 1.6 million colonoscopies. I mean, can you guys ramp up and help me out, do 1.6 million colonoscopies for us? So we're pushing mailed FIT. I've been fighting for this. It's challenging, and we need organized systems. Most of our country is designed around opportunistic screening. The provider decides what screening to offer. During a clinic visit, it's up to the provider. They can talk to the patient with shared decision-making with the patient. Follow-up is up to the doctor, and there's variable quality assurance. In an organized system, the program decides who to screen with what test. Independent providers can add to it. You can do colonoscopy if you want, but the program might say do FIT. They have tracking registries and quality assurance programs. This is what Kaiser does. They mail a letter out to people that says you're due for screening. Here's a FIT kit will be coming in the mail soon. Then they mail a FIT kit, then they have a robocall reminder, a postcard reminder, then they turn it over to the primary care clinics to do phone calls, secure messages, et cetera. And with that, to save time, I'll just say they got to 82% adherence with screening. And when they started that program, note their overall screening adherence is the top line. It went from 40% to 80%. Their colonoscopy numbers are shown here in the open squares. Those have been rising steadily since 2000 to 2015, but their FIT numbers shot up dramatically. And with this improvement in screening, with this massive mail out of FIT in 2007, they boosted the incidence of colon cancer. Now, FIT doesn't cause colon cancer, of course. They detected a bunch of preclinical disease, and they reduced colon cancer mortality. And so you see overall increasing participation in screening led to decreased mortality from colorectal cancer. So we've started doing this in the VA. We've got some pilots, but there's challenges. I mean, we have to contract with people to make the labels, mail them out the right place. One facility mailed out FIT kits to people who were due for surveillance colonoscopy. This is not as simple as it sounds. You need a system in place. In Fresno, we're getting a 45% return rate, Vegas 49%. Note those positivity rates, 7, 11%. It was 110 degrees in Vegas most of the time we were doing this. Still, we're getting high rates. I wonder what it would have been if we did it in the winter. So what are my top challenges, my like David Letterman list of top concerns? Well, we still have resistance to non-invasive screening. When I'm pushing non-invasive screening with FIT out to the community, some of my GI colleagues are resistant. They're like, we need to do colonoscopy for everyone. And I say, look at the 1.6 million number I'm dealing with. I mean, I love colonoscopy. I believe in screening colonoscopy. We just can't do 1.6 million screening colonoscopies. If we sent them all to the community, I don't know if the community could handle it or not, but it would cost a lot of money. And think about the choice data I showed you. Not everybody wants it. Give them a choice. And then if they do the non-invasive test, get them a colonoscopy if it's positive. We don't systematically collect data like we talked about earlier. I worry about overuse and underuse, the technical issues we talked about. Quality assurance, a big one. We need quality assurance for colonoscopy. I really lose sleep over all those FIT positive people who don't get scoped. We need to think about this from a population health management perspective, and it's tough in our fragmented healthcare system. But finally, I hope we can find ways to reduce those disparities in colon cancer screening. And if we do a better job, hopefully we can save those 53,000 lives. This is T-Mobile Park where the Mariners have played baseball. You all probably know we have the worst record in all of any sport, not getting into the postseason. But the point here is not about the Mariners or baseball. The point here is this is roughly this stadium holds about 53,000 people. That's a lot of people dying of colon cancer, and they don't need to. We can prevent this. And Dennis has shown us the way. Dennis has taught us all so much about colon cancer screening and prevention. And I wish he was here to celebrate the improvements we made and to talk with us today. Thank you very much for your attention. I'd be happy to take any questions. Yeah, Sachin.
That was just a fantastic presentation, really inspirational for you. Can you talk a little bit about what the VA does?
Yeah, the question is about post-colonoscopy colorectal cancer. Does the VA have any programs in place to do root cause analysis? So there's no national program in place, but individual facilities do root cause analyses whenever there's adverse events. We have a patient incident reporting system. People do those. I've been involved in some of those in my own institution. We've had cases. You think about your process of how do you notify patient results? We had a fee-basis provider who did a colonoscopy on somebody, saw a mass, took a biopsy. Biopsy came back adenomatous. The fellow reviewed the path, saw adenomatous, said come back in 5 years. Nobody, like when I see a mass, I automatically consult surgery if it's something that I know I can't take out. But this fee-basis provider didn't do that. And so then that patient presented 2 years later with the Duke's C colon cancer. So we report, we have a full disclosure thing. We talked to the patient, told them this was avoidable, this was our fault. Interval cancers are challenging to measure at the individual level. You need a big denominator. Adenoma detection rate is hard enough to measure because you need a large sample size to get an accurate calculation. But interval cancer rates hopefully are incredibly low and would be even harder to calculate what's too high of an interval cancer rate. Steve.
Jason, thanks. That was really fabulous. For the fellows in the audience, and maybe for even some of us, where do you see this going in the next decade in terms of screening tests and in terms of computerization in colonoscopy and AI? Because to me, that seems like two huge areas where we could make major improvements. Is there going to be a blood test, a spit test, something that people will be more compliant with? And can we get quality assurance done with AI and machine learning?
Great question, Steve. So I do think that AI is going to help us. I don't know if what we have today is going to be the right system or not. You know, there's AI for adequacy of bowel prep. There's AI for percent of mucosa evaluated. You know, cecal intubation. I don't want people self-reporting cecal intubation. I want the computer using like Facebook facial recognition. I don't mean to plug Facebook, especially not now, but you know, this is all doable. And so we shouldn't self-report cecal intubation. Now, when you think about percent of mucosa evaluated, what's the benchmark? It's not gonna be 100%. And can you imagine if you knew, you know, you have to report that, you're gonna be going back and forth saying, oh, I'm at 97%, can I get to 98, can I get to 99? And is that what, you know, is that gonna be in the patient's best interest? How much extra work, how much extra time, you know, can we maintain our efficiency for the healthcare system? So I don't have an answer to that, but I do think it's the direction we need to go. And some group, maybe the multi-site task force or others, will have to say, you know, you should evaluate at least X percent of the mucosa. It should be exposed. The bowel prep quality should be confirmed by AI. Your adenoma detection rate and your adenomas per colonoscopy can be done by AI. So yeah, I think we need that, but I also think we need the systems, Epic and Cerner and everybody else needs to get together and find a way to share family history data in a way that matters, prior colonoscopy, prior fit data. Let's stop wasting colonoscopies on people who don't need them and devote those resources to people who do. Now, you also asked what screening tests are we gonna be doing? You know, there's Grail and Freenome and all these other companies coming out with CancerSeek and all these other tests that are going to open Pandora's box, frankly. You know, like some of these tests have phenomenal test characteristics, but they don't know, they're not so specific for colon cancer. They say there's a cancer somewhere, now you go find it. And that's going to create a lot of anxiety for patients and for their providers. And we have to wrestle with that. I do think I'm not worried about the future of colonoscopy. Let me say that. I do worry about the future of screening colonoscopy to some extent. I think the Spanish study is going to come out saying that FIT is as good or maybe better than colonoscopy because of adherence problems. The confirmed study is going to come out in 2028, roughly. And we might find that colonoscopy is better than FIT. I have no idea. I really have no idea. If it says colonoscopy is better than FIT, then what I would do is still offer people a choice, but I'd say colonoscopy is better than FIT. You should do colonoscopy because. Right now I say you should do colonoscopy or FIT. As a PI of this study, I don't think it's fair for me to say you should do colonoscopy. I mean, I'm a big believer in colonoscopy, but I have to have equipoise. But if the study says it's better, you should do colonoscopy. And if you say no, then okay, let's do FIT as a backup plan. Did I cover all your questions? Thanks. Swati has.
Thanks, Jason. That was outstanding review. I have a comment and then a question. One comment from Finn McRae, who tuned in from Australia, and he said, wonderful talk. Very nice way to honor Dennis. My question is really, you work within an amazing integrated healthcare system, the VA system, and programmatic screening is a possibility despite all the challenges that you've talked about. And we're really excited to hear about the pilot that you have about mailed fit. But what is your perspective on how the US healthcare system, as fragmented as it is, how we can move towards programmatic screening for colorectal cancer screening for non kind of systems outside the VA or Kaiser?
Yeah, it's a great question. It's a tough one. I mean, even in the VA, we have big challenges with this. Now, when I proposed this to the VA, one of the VA leaders said, I love the idea. My insurance company mails me a fit every year. My wife works for Primera Blue Cross. They mail fit kits to rural members in Alaska and other areas. A way to reach rural people is through non-invasive screening like FIT. And so everybody's worried about their HEDIS measures. I mean, I think we have like carrots and sticks and, HEDIS measures include your colon cancer screening rates. And so if we get the insurance companies focused on this, and I think they are, give them the tools, show them that, we have these other options and help them achieve the goals they want. They want high HEDIS measures. They want high colon cancer screening rates. Then we need to move to the next thing. Like we need to make colonoscopy after positive FIT a HEDIS measure, right? If that was a HEDIS measure, we might see movement in this scarily low number. But I think we, as our professional society, need to work together to create these quality metrics and then push our legislators and our insurance companies and HEDIS I'm on the National Quality Forum's CQMC, whatever that stands for, you know, and we work together on these metrics. I'm the VA representative for that. There's people from the AGA and the ASGE and other societies on that with the insurance companies. And I think that's maybe the best we can do until we have an integrated healthcare system in the US, which may never happen. And hello to Finn. Thank you for joining.
In regard to non-invasive measures, many years ago, there was interest in virtual colonoscopy, but it didn't go very far. And despite its shortcomings and limitations, it has a lot of advantages. Is there any reason to think that it should be pushed or developed or encouraged?
Yeah, so yesterday I spoke about the different tests. I spoke about CT colonography. I think CT colonography has a role. I don't know that it's the right primary screening modality. Also, a lot of the data from CTC preceded our understanding of cell-ulcerated lesions. Those cell-ulcerated lesions are flat, and it just seems like it would be hard for CTC to pick it up. And then in fact, the Dutch study showed us that it does not do a good job of picking up these lesions. Now, FIT doesn't do a very good job of picking up these lesions either, but FIT is done every year. So when those lesions get large enough that, you know, if they turn into cancers, potentially FIT would still work if you're doing it every year and catch it. Whereas if CTC is done every 5 years, you might miss that window. So I think it's a great question. I certainly recommend CTC for certain individual patients, but I'm not sure it's a great path in the beginning. But also in my population, 46% of people have polyps. I don't know what percent have large enough polyps, but I think the rate of going to colonoscopy would be very high in my population. Perhaps in lower risk populations, you could use a test like CTC and have it make good sense.
Thank you, and thank you for your excellent talk.
Thank you.
I want to say thank you for a great talk. Sorry, I'm Prashant, one of the recently graduated fellows. I have a question for you about the racial disparities. You know, I know that there's evidence that for the Latino different racial groups, that if you have somebody reaching out to them in their primary language, so native Spanish speakers, that increases rates. Is there any data about the race of the primary care or gastroenterologist provider that is speaking to the patients and whether or not that overcomes some of the cultural barriers? Because the disparities persist even with you know, language outreach efforts?
That's a great question. There is literature on concordance of the race, ethnicity of providers with their patients in various health behaviors. I don't know if there's any, I'm not familiar with whether or not there's any data in that regard to colorectal cancer screening in particular, but we know that, you know, patients' trust levels may be higher with concordance. We also know, speaking about colonoscopy, and one of my co-fellows at Duke many years ago published a paper that still gets cited today about preferences of women for being scoped by women, right? And we know that that's an issue with that. You know, in our VA, we're fortunate to have several women endoscopists, and you know, we try to put together teams of nurses to make that a more comfortable experience for the patient. So when you think about, you know, it's not just race and ethnicity, but gender, I think plays a role here as well. Sorry, I don't have a better answer for you than that.
Take any questions from our virtual audience, if there are any, and the conversations can certainly continue live here, but we just want to thank you, Jason, for an outstanding talk and honoring Dennis's memory by being here for this lectureship. Thank you very, very much.
Thank you. I'm again honored and humbled by this experience, and I'm really grateful to Dennis's family for being here today with us. Thank you all so much.